So now I am so pleased to introduce our first speaker of this year's meeting. Dr. Jessie Rubin is a reproductive endocrinologist and infertility specialist working with Reproductive Biology Associates here in Georgia. She received her bachelor's in Science, Technology, and Society, as well as Hispanic Studies at Vassar College. She graduated from medical school at the Medical College of Georgia and went on to do her residency in obstetrics and gynecology at Emory University. She did her REI fellowship at Baylor College of Medicine. She's board certified in both OBGyn and REI. Dr. Rubin has received numerous awards for her scholastic achievements, research endeavors, and dedication to teaching, including winning the Golden Apple Teaching Award each year of her training. Throughout her residency and fellowship, she's published papers in peer-reviewed medical journals, as well as presented at several national meetings. Additionally, Dr. Rubin has co-authored book chapters on fertility preservation techniques for cancer patients. Her primary clinical interests include fertility preservation, in vitro fertilization, polycystic ovarian syndrome, third-party reproduction, and diminished ovarian reserve. Additionally, Dr. Rubin focuses on fertility preservation for women before and after cancer therapy. Dr. Rubin notes that during her training, she developed a passion for assisting couples dealing with pregnancy struggles, which reinforced her drive to help women achieve optimal gynecologic and reproductive health. She is active in the local Jewish community and has enjoyed serving the needs of women in the greater Atlanta area during her first year of practice. Welcome, Dr. Rubin, who will be giving us the lecture today, REI in 2022, Celebrities, Netflix, and Roe.
Good morning, and thank you for such a kind introduction. So I'm excited to be here today to kick off the GOGS lectures, and I'm glad everybody's back together in person. So my name is Jessie Rubin, and today I'm going to talk about REI in 2022, Celebrities, Netflix, and Roe. In relation to the presentation today, I have no disclosures of interest. So over the course of the next several minutes, I'm going to review normal fertility and aging. I'll then discuss the portrayal of fertility in the media, and then I'll conclude by assessing how the recent overturn of Roe might impact fertility care. So let's begin. When we look at the media, we see lots of women that are conceiving in their late 40s, early 50s. So Halle Berry is a well-known actress. She had a child at 47. We see Kelly Preston, another actress, had a child at 48. And Janet Jackson, a musician, she had a child at the age of 50. However, the truth is, it's really hard for women to conceive when they're in their late 40s and their early 50s. At the age of 45, the chance of spontaneous pregnancy is less than 1%. And the chance of pregnancy through assisted reproductive technology is less than 5%. And so by seeing these women in the media having children so easily in their late 40s and early 50s, it really sends a confusing message to our patients. And it helps propagate this myth that women can have children at any age using their eggs as long as they're willing to do IVF. And that's not necessarily the case. I don't know specifically about these women. I was actually not their fertility provider, but I can say unless they froze their eggs several years prior to having children, chances are they probably did not use autologous oocytes and they probably used a donor egg. But very few people talk about it, and it's really not well known. So in order to have reasonable expectations of fertility, I think it's important that we know what is normal reproduction. When I meet down with patients and I tell them their chance of pregnancy, if everything is normal, is 20% per month, they look at me like I'm almost crazy. They think it's 100% chance per month. And it's only 20% chance at best. Over the course of a year, we expect about 85% of fertile couples to conceive. And fertility actually peaks at a very young age. Women's fertility peaks in their early 20s, And this is often before women have considered having children or how they want to build their family. As women get older, their pregnancy rates decline. So this graph depicts spontaneous pregnancy rates over time, and not surprisingly, it shows that pregnancy rates go down as maternal age advances. On the x-axis, you can see maternal age, and on the y-axis, spontaneous pregnancy rates per 1,000 women. What is a little bit surprising is that we start to see pregnancy rates declining as early as the age of 32, and then a lot more drastically at the age of 37. So it really happens before most of us realize. The natural decline in pregnancy rates is really due to two different factors. It's a decline in oocyte quantity and a decline in oocyte quality over time. So let's talk about these things. Oocyte quantity. We know that for women, germ cells are continually decreasing. At about 16 to 20 weeks gestation, we have about 6 to 7 million. By birth, it's 1 to 2 million. And by the time of puberty, women have lost about 90% of their germ cells, and they're down to 300,000 to 500,000. By the age of 40, it's down to 25,000, and by menopause, it's less than 1,000. And I think what women don't realize is that each month they have about 1,000 oocytes that are undergoing atresia that are unable to be used in the future. And this is happening whether they're on birth control, whether they're pregnant. It's a continual loss of oocytes. And in fact, we only ovulate about 400 oocytes during our reproductive lifespan. So considering we start off with 6 to 7 million, 400 really is not so many. So in addition to oocyte quantity going down with time, we also see oocyte quality changing as well. And as women get older, less of their eggs are genetically healthy and would result in normal offspring. When women reach the age of 37, at least half of their eggs are going to be abnormal. And by the time they reach 45, it's thought to be 80%, and some say much higher. So we're seeing a decline in oocyte quality, which is pretty significant, starting especially from mid-30s onto women in their 40s. The decline in oocyte quality has really been extensively studied if you look at IVF literature. There was a great study by Franasiak et al., and they looked at women who did IVF of all different ages, and they did embryo biopsies. They had over 15,000 embryo biopsies, and they looked to see, based off of age stratification, what percent of embryos were genetically healthy and normal. And for women who were 30, it's about 3/4. For women who are 35, it's a little over half. For women who are 40, it's about 40%. And for women who are 43, it's just above 15%. And I show this because a lot of times we see women, in the office, and they'll be 42, 43, 44, 45, and above, and they'll look at me like, what do you mean not all of my embryos are healthy? How could all of my eggs not be healthy? And it's just a nature of time, and oocyte quality changes. But it's important, if you have a patient that's thinking about IVF or having fertility struggles, especially if they're 35 or above, it's really important to get them with an REI provider, because we see such a difference in success rates with IVF beginning for women in their mid-30s. The reason we see changes in oocyte quality over time is because an increase in oocyte aneuploidy or abnormal eggs. And this is just due to altered regulatory mechanisms. The regulatory mechanisms that determine where the spindle apparatus is positioned, which ultimately affects chromosome alignment and affects the number of chromosomes in the cells, becomes altered. And so you end up with some cells that have too much genetic material, and you have some cells that have too little. It's errors in meiotic segregation, normally with non-disjunction. So because we see changes in oocyte quantity and oocyte quality over time, it's not surprising that pregnancy rates decrease over time, and that's the purple line. And then also that risk of miscarriage goes up with advanced maternal age, and that's the line in green. So, what's interesting to me is we spend so much time, talking about fertility and trying to make sure people know that as they get older, it really is harder to achieve pregnancy. And nowadays we have more and more women that are deciding to delay childbearing. And so we're seeing fertility rates, at least about 15% of couples are going to experience this. Fertility, specifically infertility, or probably as it should be called subfertility, because they're not really all infertile, but infertility is defined as women who are less than 35 if they're unable to achieve pregnancy after 12 months of unprotected intercourse. For women who are 35 or older, it's failure to achieve pregnancy after 6 months. And I just want to mention that if you have a woman who's 40, interested in childbearing and has not conceived right away, then it's important to send them to an REI just because they're going to have some challenges with oocyte quantity and quality. So, what's interesting is that we also spend so much time when women are younger telling them how not to get pregnant. We talk about birth control, and there are ads for birth control and all of those things. But women, when they're young, they're often not told that it actually might be hard to get pregnant when you're ready to get pregnant, especially if you're of advanced reproductive age. And so I think as medical providers, we have an obligation to talk about fertility. I know it can sometimes be a little bit uncomfortable, but if you have a woman who's of childbearing age and you think she's interested in having children or having more children to expand her family, it's a really good time at her annual visit just to say, hey, are you interested in having more kids? Would you like to look into that? And one of the things that can be done relatively easily is testing ovarian reserve. So I'll talk about that in just a moment. It's also a really good time to encourage positive lifestyle habits. Some lifestyle habits can actually impair fertility, and so it's really good to make patients aware of this. And then also, if somebody's interested, discussing fertility preservation as well. So ovarian reserve, it's testing a woman's oocyte quantity, and it's important to do because even though women are born with all of their oocytes, that number of oocytes is going to decline over time. It doesn't always decline at the same rate for all women. The tests that I use for ovarian reserve, and which are pretty standard amongst fertility doctors, is anti-Mullerian hormone and antral follicle count. Anti-Mullerian hormone is easy to do. It's a blood test. It's looking at a hormone that's secreted by primary, secondary, and preantral follicles. And so by nature of this hormone, it's reflective of the oocyte pool that women have. One of the nice things about AMH testing is that there's really no intercycle variability. It doesn't matter where they are in their menstrual cycle. They don't have to be fasting. It doesn't have to be in the morning. It's a really easy test to do. The normal level for AMH is going to vary depending on the age of the woman. In general, less than 1 is considered low, but there's normal ranges depending on how old the woman is. Another test that's relatively easy to do and very helpful is antral follicle count. It's doing a transvaginal ultrasound, looking at the ovaries, and measuring the number of antral follicles, which are tiny little follicles measuring between 2 to 10 millimeters in both ovaries. A low antral follicle count is typically less than 8. This one, you have to keep in mind there's other things in their medical history that might slightly impact their AFC. For example, a woman with PCOS is going to tend to have a high AFC. A woman with hypothalamic suppression or on birth control might have a slightly lower AFC. Other tests that are done not infrequently is day 3 testing. So on day 3 of the menstrual cycle, you can check FSH and estradiol levels. This one's a little bit harder because they have to be towards the beginning of their menstrual cycle. And so I don't routinely do it unless for certain insurance companies they require it. But there's a lot of intercycle variability with FSH testing. And with FSH testing, if you're going to use that, you also need to check an estradiol level at the same time. An FSH that's normal should be less than 10, and the basal estradiol should be less than 60 to 80. You have to check them both together because an elevated estradiol can falsely suppress FSH, and so they both need to be interpreted at the same time. It's important to know, though, that these markers are looking at their pool of follicles, but it's not a pregnancy predictor. And so by looking at somebody's ovarian reserve testing, you cannot predict whether they're going to be pregnant or not. There's no test that is easy enough to say this person will become pregnant, this person will not. This is more of a predictor that will look at how would they do in a stimulated cycle of IVF, meaning how many eggs would they get? Are they a good IVF candidate? Are they good at responding, and will they grow a large cohort of eggs? When women have a low AMH, I know it's a really difficult conversation to have. They automatically think they'll never get pregnant. I remind patients, I've had patients with AMHs of 0.03 that got pregnant. And not only that, they got pregnant on their own. I had a patient last month with an AMH of 0.04. She got pregnant on her own. So it doesn't mean that they cannot get pregnant with a low ovarian reserve, but it does mean that if they're not ready to have a family or they're having trouble conceiving, they really should be proactive about it and see a fertility specialist. The other thing that plays a role in ovarian reserve is lifestyle factors. So when taking a history, I always ask about cigarette smoking. Cigarette smoking delays time to conception. It also is that smokers are more likely to be infertile. And the reason why is it increases the rate of oocyte loss. There are studies that have shown women who are smokers go through menopause earlier than women who are non-smokers. It also potentially has a role on oocyte quality as well. So talking about smoking cessation is also very important for ovarian reserve. And then obesity. Obesity is a worldwide pandemic. We all practice in the South. We see it every day. You sort of get immune to it, and looking at BMIs, especially BMIs over 30, they're kind of the normal now. And we need to make sure if somebody's trying to get pregnant that we're talking about it. Obesity is associated with ovulatory dysfunction and menstrual irregularities. It affects sex hormone binding globulins, which lower gonadotropins, which leads to irregular menstrual cycles, and therefore it's harder for these women to get pregnant. The pregnancy rate I told you in a normal fertile couple is about 85%. If a woman's obese, her pregnancy rate 1 year after stopping birth control goes down to about 66%. So it's a pretty sharp decline. Women who are obese are also less responsive to fertility medications. So that means they need higher dosages of medicines. They might not respond. It's extra cost to the patient. And also, obesity affects their oocyte quality. If you look at the oocytes of a woman who's obese after IVF, there's less cellular content and there's higher triglyceride components in those oocytes. So obesity and cigarette smoking, they impair fertility. They also do a host of other things everybody here knows about, like perinatal and fetal complications. But the reason why I mention it in this talk today is because when women are trying to conceive, it's one of the times that they're most willing to listen to their medical providers and do what we tell them to do. I have patients tell me, if you tell me to stand on my head for 20 hours a day, I'll do it. And I know they would. If I tell them, you really need to lose weight, this is our BMI threshold, I see a lot of patients that take it very seriously. They come back and they've lost a significant amount of weight. And so it's a time when people are preparing for conception. They're, I think, particularly sensitive to listening to their doctor's advice. And sometimes this information is better received and they're more motivated. I also think if someone you're seeing and you're checking ovarian reserve and they're not ready to have kids or they're thinking about it and they don't quite know what they want to do, it's good to just tell them that fertility declines with age and they should see a reproductive specialist. Egg and embryo cryopreservation is something that's really good for people who want to delay childbearing. It's most cost effective around the age of 35 to 37, but I see women younger, I see women older, and it's really good to discuss at any time, especially if a woman is particularly high risk, like she has recurrent ovarian cysts or she's had a unilateral oophorectomy or something like that. You might want to get them in sooner than their mid-30s. And then, the success rate really just depends on how old the woman is when she decides to do fertility preservation. And if they have a partner, embryo freezing can sometimes be helpful because it lets us to genetically test the embryos and know how usable what we have frozen might be. Also, I just want to mention an aside because I started with talking about women, in their late 40s and 50s getting pregnant. If you have someone who's 44 and above, they're not a great candidate for egg freezing. I see a lot of women 45 and above who are interested in it. And that's a really good time where you know, it's not harmful to do, but it's not going to be successful. And so you really want to start to introduce the topics of donor eggs to women who are 44 and above, or who have a very, very, very low AMH. So, you know, in summation, celebrities in the media, they're not really accurately portraying the impact of age on ovarian reserve. We're all having a harder time getting pregnant as we get older. And it's important to counsel patients that their reproductive potential is going to decline over time. And it's important to offer ovarian reserve testing, tell them about lifestyle factors like smoking and obesity that can help improve pregnancy, and also refer them to an REI if they're interested in fertility preservation. So we can also, you know, we can educate our patients on age and fertility. We can talk about it all the time, but we have to keep in mind too that in today's culture, a lot of people are getting their information not necessarily from their doctor, but social media and the internet has a really big influence. So especially when it comes to fertility. In today's era, most people get their information from television, social media, the internet, their friends' experience. You know, even though infertility affects 1 out of every 8 couples, there's still limited awareness and a limited understanding that surrounds infertility. And we know that life is not just a sitcom that they see on TV. You don't identify a problem, solve it, put it in a tiny, you know, nice, pretty little package, and that's all done in 30 to 60 minutes. It just doesn't happen that way. And anyone struggling with infertility knows the real life storyline is a lot more complicated, and it takes time, and it's not always successful. So we have to be careful what patients are seeing as what a normal fertility journey is supposed to be based off the media. Thankfully, the media is discussing fertility more commonly. It's often more thoughtfully, and sometimes it's actually more accurately too. So there have been some shows that have paved the way for talking about fertility struggles and trying to remove the stigma that surrounds infertility and infertility treatment. One of the first shows was over 20 years ago on Sex and the City. The protagonist was going through IVF. And in order to try to improve her outcomes, she decided she wanted to do acupuncture. And this was one of the first representations of IVF on TV. And you know, over 20 years later, we're still debating, is acupuncture helpful or not in IVF cycles? So that part hasn't changed. Basically, it hasn't statistically shown that acupuncture improves IVF success rates, but it also doesn't harm them. So I really kind of counsel patients, it's up to your preference. If you want to do acupuncture, certainly you can and it might be helpful. And if you don't want to, that's okay. You don't have to. There's also another show that recently talked about fertility. It's a show called This Is Us. And I mentioned this one because they really talked about some of the difficult challenges with fertility. So this protagonist has PCOS, she's obese, and she's got infertility. And over the course of the show, they talked about some of the really difficult topics, such as PCOS and obesity, and how obesity can affect fertility. With this protagonist, she was trying to do IVF, and her BMI was too high. And they talked about that and how your BMI needs to come down before you can do IVF. The reason why we have BMI cutoffs for IVF is because when we do the egg aspiration, it's called the transvaginal oocyte aspiration, it's done under anesthesia. And so there does need to be some BMI threshold. It's also a surgical procedure. And each clinic has their own threshold for what a maximum BMI is. At RBA, we like the BMI to be 43 or below before they start IVF, but you can find it's different for every clinic. Regionally, it's actually very different as well. I trained in Houston and then going to Atlanta. I have friends who are in New York, completely different BMI ranges, you know, from state to state. But it's important to talk about, you know, some of the difficult topics and raise awareness that there are BMI thresholds. There's also been a series of documentaries, both positive and negative recently, that have come out talking about fertility. And I have patients who watch these all the time and they'll come ask me questions. So One More Shot was one documenting a couple's fertility journey. Exploitation looked at egg donors. Some of y'all might be familiar with Our Father. It was trending #1 on Netflix last month for like 2 or 3 weeks straight. It looked at the improper use of sperm donation. And and there was also one called Modern Baby. And Modern Baby looked at a couple of different couples, and what was nice was they all were going through a different journey. One was going through IVF, one was doing egg donor, one was a same-sex couple. But they showed that, infertility is not a one-size-fits-all. Not everybody looks the same. Not everybody has the same journey. And these documentaries have really done a good job of trying to help raise awareness. But you got to keep in mind that some of this information is accurate and some of it not necessarily. So the media has a really big influence on what people know about fertility care. And as providers, our job is to educate them. So we need to know what they're exposed to. Some of the benefits of having all these recent documentaries and attention towards fertility is it increases awareness. It's important for people to know it's 1 out of every 8 couples. It also helps remove the stigma around fertility treatments. It's really hard for patients to go through infertility because they feel really isolated. I've had times where they don't tell their family members that they're going through it. And I've actually had cousins that bumped into each other in the waiting room and they had no idea the other one was struggling. It's such a private journey and it's really, really difficult. And I think by raising awareness, it helps remove some of that stigma. It provides education, which is important. And it also, for some, can provide a sense of emotional support. It can also be concerning and not always a good thing. Sometimes it disseminates inaccurate information. Sometimes it's simply just anecdotal experience. Sometimes the documentaries are relatively older, and so what they show and how we used to do fertility treatment is not accurate with how we still do things. So some of the older information on fertility looked at how we used to freeze eggs and embryos, and there was a process called slow freeze. It's now done with something called vitrification, which is a rapid freeze. And the success rates are drastically different. So people have this perception that eggs and embryos don't survive the thaw when you go to use them. But in fact, 95 to 97% of embryos are going to survive the thaw. And so people rely on this older information, and it's not always accurate. It also, for some, can exacerbate isolation with infertility. If they're going through fertility struggles and they see all their friends on social media getting pregnant and all their friends in the chat groups and on these blogs getting pregnant, it can sometimes make them feel really isolated and alone. So I think the way that we really make a difference is education. Social media is not going anywhere. It's continuing to be present, and it plays a really big role in the lives of our patients, so we have to be aware about it. It's important during GYN visits, promote an open discussion. Ask them if they're interested in fertility. If they talk about it, try to dispel any myths that they might mention about what they see about fertility in the media. And very importantly, direct them to somewhere where they can find accurate information. I use ASRM, American Society of Reproductive Medicine, all the time. I direct them to go to www.asrm.org. And the reason why is when you go to this website, you'll see 2 boxes. The blue box on the left is directed specifically for patients. And so it has information that's easy to understand. It talks about everything from ovarian reserve testing and HSG. They have literal fact sheets you can print out, to talking about different types of infertility and different types of treatment. It's important that patients are looking for information from the internet. You need to direct them to a source where they can find accurate information. It's also really nice to use ASRM because it's completely free. It's very well organized. You know it's checked by medical professionals, so it's going to be accurate. And it's not written in medical jargon. Sometimes I have patients that will, print out lots of journals and they'll try to bring it to me and come up with a synopsis, but the paper was in medical jargon. They don't really understand what it meant. They have no idea what they're reading, and they'll ask me to kind of decode what it is. It's good to direct them to a source where they'll be able to read it and understand it pretty easily. So, in summation, fertility is commonly discussed in the media. It's just something of the times and something that we have to understand, but it's important. Our role is that we know there are all these outside influences, but we really have to direct our patients to reliable sources. In addition to the media influencing our patients, we also are seeing lately that the media influences politics. people's thoughts on reproductive health. They're all really intertwined in a way. So I want to take a moment and talk about how all of the recent news, especially politically, have the potential to impact some of the fertility care and the treatment that we're able to provide. So let's begin with just a little bit of a brief history so everybody's on the same page. In 1973, Roe v. Wade essentially said that women have the constitutional right to abortion. Protected under privacy laws, 14th Amendment, they have the right to abortions. In 2018, Mississippi passed the Gestational Age Act, and this act prohibited abortion for most women. There are some exceptions after 15 weeks. And that's really what was the impetus for Dobbs versus Jackson. And this Dobbs versus Jackson case questioned the constitutionality of Mississippi's law if there was an ability to ban abortion. And ultimately, at the end of June, it overturned the decision of Roe, and it said abortion is no longer considered a constitutional right, and it's no longer going to be determined on a national level, but rather states have the authority as to regulate abortion how they want to. There were 13 states that had trigger laws that ultimately prevented abortion. So here is a map of abortion laws by state. It was as of the end of July, and what we see is that the decision of the U.S. Supreme Court to overturn Roe v. Wade really has wide-ranging implications on reproductive autonomy. I'm not going to get into the politics whatsoever of termination, what's right, what's wrong. What I just want to show here is every state has the ability to choose what they want to do, and it's constantly changing. So what it might look like today is going to be different potentially than what it could look like in a few months, in a few years, in a few decades. So in Georgia, our current law is that abortion is legal up until the start of embryonic cardiac cell activity, which generally is about 5 to 6 weeks when you start to see cardiac cell activity. Fortunately, there are exceptions. A futile pregnancy, so if a pregnancy is anencephalic, that would fall under a futile pregnancy. Ectopic pregnancies, thank goodness, because last week on call I had a C-section scar ectopic. Thank goodness that was covered, because I was thinking I can't imagine our colleagues in states, where they wouldn't have had that luxury. Medical emergencies, and then rape and incest with some caveats, assuming they're less than 20 weeks and it's reported and there's a police report. So this law became effective relatively recently at the end of July. And, looking at how this might impact fertility care, sometimes it's not always a direct link, because the intended consequences was really to restrict abortion. As far as we know, it wasn't to talk about IVF and fertility care, but it might actually have some impact on the ability to do IVF. And in order to really understand that, I think it's important I explain a little bit about IVF so that you understand how these political decisions might impact our ability to provide care. So IVF starts with the recruitment of multiple oocytes after gonadotropic stimulation, typically for about a 2-week time period. Then there's an oocyte retrieval where you can see in the image there is a vaginal transducer probe, a 17-gauge needle. It's used to aspirate the follicles from bilateral ovaries. Those eggs are then fertilized in the lab, and they're grown and what we call embryos, which are fertilized eggs. Ultimately, when a woman's ready to get pregnant, the process will culminate in an embryo transfer. When you look at normal embryonic development, it starts with one cell. That cell is then fertilized. It goes to 2 cells, 4 cells, 8 cells, something called a morula, which is a cluster of cells, and then finally, the final stage of development, which is called a blastocyst. And on that top row, you can see normal embryonic development. But what we also see quite regularly and every day is abnormal embryo development, or what we call arrested embryos, meaning they might fertilize, they might divide a couple of times, but they don't always make it to the final stage of development, which is blastocyst, where we typically do implantation. So embryos typically will sit in the lab for 5 to 6 days, and not all of them are going to progress to that blastocyst stage. So in both nature and IVF labs, most of the eggs do not result in pregnancy. And that's why ideally when we're going through an IVF cycle, we want to get as many eggs as we can at the time of retrieval, because we know there's going to be an attrition from the number of eggs you get to the number that fertilize to the number that grow to the number that ultimately implant. The majority of the eggs that we get are either not going to fertilize, not going to grow to development, or not going to ultimately implant into the uterus. And it's important to understand that embryonic failure is normal in reproduction. It's normal naturally in the body. It's normal in an IVF lab. There's a wide variety of reasons why women might need to go through IVF in order to achieve pregnancy. They could have infertility with tubal factor and their tubes aren't functioning. They could be wanting to do fertility preservation, either for elective egg freezing or they're about to get gonadotoxic treatment and they need to preserve their fertility. Could be third-party reproduction with a gestational carrier, or we're seeing a lot also of genetic screening to prevent disease transmission. It's become very common that patients either have an autosomal dominant mutation themselves, or they carry an autosomal recessive mutation that their partner also carries. And so they'll come to me looking to do IVF so that they do not pass this genetic disease onto their offspring. So for example, last week I saw a couple where they had a child spontaneously. Unfortunately, that child has cystic fibrosis. So now they're going through IVF so they can do genetic testing to prevent having another child with the cystic fibrosis. And so, IVF is commonly used for a multitude of reasons, but for some of our patients, it really is the best option for them to do care. Since 1981, there's been more than 1 million babies that have been born with IVF. And in 2019, over 2% of US births were via IVF. So it's become very, very common. Where we look at overturning of Roe and the potential impact, what we see is that it might limit reproductive care when it comes to IVF. And that's because currently in the state of Georgia, we define life or personhood at embryonic cardiac cell activity. But it's not the same in every state. And in some states, personhood is defined as beginning at the time of fertilization. And if we decide that in Georgia, personhood is also going to be defined as beginning at the time of fertilization, then technically each embryo or each fertilized egg has personhood. And there's the possibility that it could have protection under state law, each embryo. And these laws could dictate how we practice IVF and what is our standard of care and how do we provide safe care to patients. So the current IVF standard of care is we get as many oocytes as we can safely with controlled ovarian hyperstimulation. We then will fertilize the eggs and we'll culture the embryos in the IVF lab. We limit the number of embryos that ultimately get transferred to a woman's uterus, and we tend to freeze access embryos in cryostorage. The reason why is we don't want to transfer several embryos to a woman's uterus because that's going to increase her risk for multiple gestations. It's going to increase her risk for antepartum complications, fetal complications, etc. We also do not transfer genetically abnormal embryos. So if an embryo is affected with, for example, a specific disease, like the example of cystic fibrosis earlier, we wouldn't transfer that embryo. If an embryo has an abnormal content of chromosomes, it would never result in a healthy pregnancy, we don't transfer that embryo. And that's pretty standard across all IVF clinics. When we think of embryos as having personhood, the climate really starts to shift a little bit. And there's going to be a concern about how do we culture embryos, how do we freeze embryos, and how do we discard them? And new legislation might criminalize physicians for routine IVF care, and we might see changes in clinical practice. So right now we're culturing embryos in the IVF lab, but if embryos arrest and each embryo has personhood, there's thought that the physician might become liable. So what do you do when these embryos naturally arrest? Another question is when you freeze access embryos in cryostorage. Well, 95 to 97% of embryos with current vitrification technology will survive the thaw, but what happens if they don't? And we also limit the number of embryos that we transfer, but if we're nervous to culture them in the IVF lab and we're nervous to freeze them, are we going to start transferring more embryos because we have no choice and you can't discard them? But that also leads to multiple gestations, risk of ovarian hyperstimulation, several complications not in the best interest of patients. And then also a really tricky one is that we don't transfer genetically abnormal embryos. And I don't really have a solution for that one. That one is just tricky, and I don't know what we would do. So the way that the overturn of Roe could impact fertility care is that physicians could become liable as a result of routine biology and embryo arrest. Embryos arrest, they don't always implant, they don't always surviving the freeze and thaw process, and those are just kind of natural facts with biology that would really be affected if personhood was defined at the point of fertilization. The other thing that would become an issue is embryos when they get discarded. So currently embryos are discarded in the lab if they're ineligible for transfer, for example, if they're genetically abnormal, or they're also done if a patient has completed childbearing and they feel like their family is complete. Then they have a choice of what they do with their excess embryos. And they can donate them to another person with infertility. They can donate them to science. They can continue to pay to store them, or they can have them discarded. And that would become, the patient's choice at the moment, but may not always remain that way. There's also a lot of potential consequences to the patient. So if they have multiple embryos fertilized, we don't want them to have multiple gestations. We don't want them to have ovarian hyperstimulation, which is a risk with hypercoagulability, can lead to stroke, can lead to death. Patients don't want to have children with disease transmission if they can prevent it. And that would really, potentially cause some complications. They also might be unable to discard their excess embryos when they've reached their ideal family size. And if each embryo is considered personhood, we might not be able to donate embryos to science anymore. And a lot of the advancements in the IVF field have come from women and couples who've donated their embryos to science so that we could advance our understanding of embryology and the embryonic development. So, the way that I think we make a difference here is we raise awareness that legislation could impact access to safe care. And this could be people who are aspiring to build their families with IVF, or it could also include your patients who've already built their families and they're wondering what to do with their excess embryos. I have had countless phone calls over the last few weeks asking, okay, I'm ready to ship my embryos, where should I send them? I've got my credit card info, where do you think they should go? And I'm like, hold tight, we're not telling anybody to ship embryos at the moment. And they said, but what about these other states? There's questions of if IVF is going to be challenged. I'm ready to go, where do I send them? And, the ultimate message is we don't know what the future holds. But we do have to be cognizant of what's going on and make sure that we're proactive and aware of all of the potential downstream effects. It's important people are educated about how legislation impacts medical care. It's important to encourage people to vote and to reach out to their senators and their representatives and make sure that whatever their opinions are, that they're heard. So, in summary, if I could send you home with a couple of takeaway points from this morning, it's number one, ovarian reserve declines with age. We know that happens. Celebrities don't have golden eggs. None of us have golden eggs. I can't tell you how many times I hear, well, I look so young. And I'm like, you do, you look great, but you're still 48. Or, it doesn't matter. Or I Botox my face, can you Botox my eggs? I'm like, it doesn't work that way. So, tell people, unfortunately, we're all getting older, but, if you do want to have children and you want to delay childbearing, just be proactive about it. That's it. Also, be aware that patients are exposed to the media. It's not always accurately portraying fertility. And so it's important that we're sending the right message to patients. And then lastly, it's important to advocate for reproductive rights. As physicians, our goal is to stand up for our patients and to do what's the right medical decision and to keep them safe and minimize complications. And so, be an active participant in women's health care and make sure you also encourage patients to be active as well. So thank you guys so much for your attention. I know I'm bright and early in the lectures, but I appreciate everybody's attention this morning. And if you've got any questions, I'm happy to answer them.
I'm curious, I've been seeing more patients when they come in for an infertility evaluation that they've done these home male test kits. Can you address what is that testing for and how accurate is it? Do you still push for the formal semen analysis in that scenario?
Great question. So more and more patients are getting advertisements for home fertility tests. I think they send them to anybody in reproductive age because I get them somehow. I can be looking at CNN and I'm getting, any news site, I'm getting ads. They're not very accurate. So in summation, there are tests you can do that look at ovarian reserve. There's actually a couple of them now that are out on the market. You can give them a sample and they'll send back the test results. What I'm finding is that oftentimes they're falsely elevated, and it gives patients a sense of reassurance. If the test is not processed properly, even if it's left out for too long, it can falsely elevate the results. So I've had patients that did fertility testing at home. They said, oh, wow, my ovarian reserve is excellent. I was told I was older, but mine's great. And then we actually do a blood test in the office and it's much lower. And so I typically don't recommend them. If they've done those testing kits, I repeat them in the office. Semen analyses, I think, are a little bit better. They're not always accurate, a little bit better, but I still do a formal semen analysis in the office because I know that the sample is processed correctly. And often when they do the home testing kits, they don't look at all the different parameters of a semen analysis. So sometimes it'll just say sperm present or absent, or sperm motile or not motile, but it doesn't tell you, is it a normal number of sperm? Is it a normal range of motility? What is the morphology? So they tend to be not particularly helpful.
Hi, good morning, and I really enjoyed your lecture. I have a question about patients who want to have testing even though they're on birth control. You have a lot of people, you start having a conversation about your reproductive history, but they're maybe 36, have to finish school, and they're on different kinds of birth control. Can you give us some insight as to what tests might be appropriate, what may be affected, which of those three tests, the AMH level, FSH, which we should delay with what kind of birth controls?
Good question. The short answer is all of them can slightly affect ovarian reserve testing, but it's still okay to do. I still tend to check the AMH and the AFC. If a woman's result comes back lower than what we expect, I'll tell them, if they're sexually active and they're willing to go off birth control and use another form of contraception, to do a washout period for around 2 to 3 months, and then we can always recheck it. I've had a lot of women who are interested in egg freezing. Their egg count will be relatively low while on oral contraception. We'll do a washout period. Their egg count gets much better. We'll do a cycle of fertility preservation, and then they'll go back on birth control.
Good morning. Thank you for a timely talk. I have a question, I guess, as a person earlier in my career and also practicing in a college town. I have a lot of young 19, 20-year-olds, healthy people generally talking about contraception. Not infrequently get people that are like, oh, my sister or my mom had trouble getting pregnant. I want to be tested to see if I can be pregnant. And how early would you recommend initiating ovarian reserve testing, or is there an age at which just kind of counseling about lifestyle factors would be more appropriate?
I would do a quick history with those patients. I would ask them, do you know how old your mother was when she went through menopause? Do you know if your mother had any trouble getting pregnant? Do you know if she had fibroids or endometriosis? And sometimes they know a lot, and sometimes they have no idea about their mother's medical history. Generally, if you're going to check ovarian reserve, you don't have to start when they're a teen or really, really young. Typically, mid-20s is a good time to check, unless you know that they have, some family history, risk factors that might make you do it sooner. And it could be as simple as also, too, in those patients, just an AMH. It's not a perfect test, but at least gives them an idea of where they are.
Hi, great talk. I have a question. It might be somewhat controversial. So if you have a patient that you're trying to get embryos from, and the only one that that you got after doing testing had like T21. If that person still wanted that embryo implanted or transferred, would you do that, or is that a personal decision, or is that all the REI say we don't transfer abnormal embryos? And with this situation that's happening, do you think that, I mean, I know you said it's possibly more abnormal embryos, but especially with T21, it's kind of a real controversial thing that some people feel that that's not a bad abnormality and it is compatible with life.
It is. And trisomy 21 I specifically did not mention because it is so controversial. So I'm glad that you asked it, because I chose a controversial topic this morning. So, it's tricky. When we talk about genetically abnormal embryos, if they're not compatible with life, it's a lot easier. You don't transfer them at all. I personally have not transferred any embryos that have trisomy 21. I've not had any couples that want to. I would say the majority of clinics do not transfer trisomy 21 embryos. You'd be pretty hard-pressed, I think, to find a clinic that does. It is controversial because it can be compatible with life, and trisomy 21 can really present with a wide variety of presentations. Not everybody is the same, not everybody's as severely affected as the others, but you have a really hard time getting clinics to transfer abnormal embryos. The caveat is mosaic embryos. Mosaic embryos mean they've been biopsied and they see multiple cell lines, multiple answers, and those are stratified into higher risk and lower risk categories, and low mosaics have been transferred and have resulted in healthy pregnancies.
So this falls in the celebrity pregnancy realm. Does the ASRM have any policy about counseling people that have had IVF or any kind of ART about delivery, timing, and route? Because they come to me and they want to have their baby at home in the bathtub. And I'm like, honey, you're 44.
Yeah.
Like, what are we doing?
Absolutely. And I actually, whenever anybody mentions they want to deliver their baby in a bathtub, regardless of the age, I do everything I can to stop and tell them that's a terrible reason for many, many reasons. And I actually sometimes print out the ASRM or ACOG. One of them has a great bulletin on why it is not good to deliver at home in the bathtub. But for women who are 44, 45 and above, we do extra counseling. So in our clinic, anybody who's 45 and older has to go through more screening before we'll ever do fertility treatment. This includes, in addition to the normal infectious disease labs, blood count, thyroid level, uterine testing, etc., we have them see an MFM and talk about the risks of advanced maternal age and how it could impact antepartum complications, delivery complications, fetal complications as well. We also have them do a urine analysis, an EKG, just basic medical screening to make sure that they're healthy to the best of our knowledge before we do get them pregnant. And it's something we spend a lot of time talking about because it really does increase the risk when, they're in their late 40s, even early 50s, and they decide they want to have a baby. We also have an age limit for people who want to reproduce. It's different per clinic. Our age limit is 55. I know, right? It's old. After a lot of screening, it's old. Most clinics choose somewhere between 50, 55. Some are a little bit more lenient, but it's scary, yeah, and they have to be really well aware that there are risks.